Hi, everyone. Um, so I would just like to introduce our guest lecturer for this session. We have Shivani Jain, who is a fourth-year medical student at the Louisiana State University Health Sciences Center in New Orleans, who actually took part in the same PNHP internship in the summer of 2021. She served on the board of her school's SNAP chapter since 2020, both as a board member and as its president. She previously completed a year-long term as a student representative of the Louisiana State Medical Society's Board of Governors, on which she is able to relay the views and concerns of students throughout her state for the purposes of policy proposals. She's also extensively involved with the AMA, APA MSA, SNMA, and LMSA, through which she's been able to engage with others on complex health policy issues and to build advocacy and resolution writing and presentation skills. She has served as her medical school STARS Fellow, where she completed projects that evaluated the implementation of choosing wisely guidelines at hospitals across the greater New Orleans area and to improve health literacy at point of care. She will be talking to us today about this application of microeconomics in the current American healthcare system. So please join me in welcoming Shivani to our virtual session today.
Thank you so much, Stephen. That was such a sweet introduction and way overdone. But thank you. I look forward to presenting with you all this kind of scaled down version of a larger talk. And it's actually been something I developed with a co-intern that year in 2021. We developed it further. And I hope you enjoy it. I don't know how much you've covered this topic already in the internship, but please feel free to interject. This can be casual, ask questions, and we'll have like a discussion at the end. So I'm going to talk about why the free market essentially can't save healthcare through a simplistic seeming example, but you'll see why. So foundationally, the 7 principles at a more basic level of the free market are: one, that there are a large number of buyers and sellers, that there's this homogeneous product, there's no entry or exit barriers supposedly, that you have perfect information, that benefits come from payment, that you can be guaranteed that the price that you're paying accounts for all the costs that went into manufacturing, and that really there's profit maximization at the end of the day. So keep this in mind as we go through. We're going to be looking at an example we've done before and it worked pretty well, of just taking into account like just a number 2 pencil. In the past, we've done other product commodities. A lot of people like to compare to agricultural products that most everyone universally can relate to and that sort of stay stable over time. But this is just a basic example of something most people have encountered and use frequently, and it's low cost, right? But a number 2 pencil, we're going to compare that, which maybe does more or less follow those 7 principles, not perfectly, but getting close, versus our healthcare system. So with that first principle of large numbers of buyers and sellers, yes, while it is true that for like something like a number 2 pencil, there are many different pencil manufacturers that exist out there. And the manufacturers, the companies that are making this, are the price takers. There's only a few or maybe, a handful of companies that really monopolize this market worldwide, but they're the price takers. Whereas everyone else that's using this, maybe more so now, not in our age. I don't know how many people are actually using pencils, but work with me on that. The consumers are the price takers. We just take what we're given. And then when it comes to healthcare, especially in our country, many Americans live in an area where the population is just too low for competition. There are not enough numbers, folks, for there to be enough driven competition, for there to be competitive bargaining. Hospitals and clinics act as the price makers. They are really setting those prices for different services, and it's not necessarily driven by the manufacturing costs as a whole. And consumers, all of us, are still the price takers, even though this doesn't hold up, this model. So then this is just kind of a map that we had showing where half of Americans live, but the population is actually too low for competition. Even though this is some years outdated, this is still actually overall pretty true in terms of what it holds up. So then principle number 2 gets into this homogeneous product. The number 2 pencil, again, it's the same product regardless of the manufacturer. There's gonna be little things that change. Maybe, oh, it's a mechanical pencil, it's this and that, little bells and whistles. But really, it's more or less the same product that you can kind of depend on. The quality will be roughly the same at a given price point, right? But that is not necessarily true. And I think you all may have been talking about this in the internship so far with many examples. right? That our healthcare system, there's so many different opinions from physician to physician or clinician to clinician on what a patient should do, even with the same physical exam findings, the same history, the same presentation. And there's even the same diagnosis at play or differential diagnoses. There's lots of ways a treatment plan can go. And that's not necessarily a bad thing. Sometimes we have guidelines from different societies. And we have evidence-backed guidelines that can help us get to like, well, this should really be the standard of care. This should be the treatment approach. And we have algorithms that we use a lot in medicine. But even within that, it's an art of medicine, not exact science. And there's a lot of wiggle room for which way one clinician will go or another practice. And it's good. We have flexibility. We have we have diverse populations with diverse needs, and we need to be resourceful and flexible. And there's evolving needs. But this also makes it really tricky for it to follow this principle. And it also makes it difficult to measure the quality of what one person's getting at one point in time versus another point in time, and what one group of people, one person's getting versus another. So that's a conflict here, right? And also, I do want this to be a conversation. If you guys want to jump in and add an example at any point or something that like sparks your interest that's come up in the internship so far, please do. You can unmute. So then, sorry, go back. We have principle number 3 that we alluded to before. No entry or exit barriers in this perfect system, right? With the number 2 pencil, there are no legal or societal restrictions holding a manufacturer back from entering the market. It's not a contentious issue so much. Consumers can choose to enter or exit into this market freely also. No one's really like worried about how many number 2 pencils you're buying. It's not regulated. It's a free-flowing good, and yeah, it's pretty simple and easy to see that it's not regulated, and anyone can come into the market today and be like, I have a better pencil, I'm going to start making it at mass production. Healthcare providers, though, it's really hard to just enter this convoluted, complex market. There's a lot of training required for what we're doing, licensure, all the steps we take to get to be able to provide care for populations, and it's as it should be. We want our orthopedic surgeon, we want our primary care practitioners to have the best training they could have, to pass their boards, to have all these checks and balances. And patients also have very little choice to enter and exit the healthcare market. We don't choose to get sick or to get, triggered to have an autoimmune condition or to come upon a cancer diagnosis. It just happens to us. Life happens. We're living beings that just have things happen to us. We're also just tied to the networks, the way our system is set up. And I know you've probably discussed this. We're tied to certain plans and networks, and we can only see a certain set of practitioners sometimes within those networks. And sometimes they can change without any rhyme or reason to us, and they can be completely gone. We had a good relationship we were building, but maybe for whatever reason, the company that the practitioner was based at has changed hands, or they've left practice, or now they're not covered by that provider network. So that leaves us in a bind. And this can happen with medications. It's even happened to me with some of my autoimmune medications, and it can be really scary and hard to manage. We also just have necessary treatments. We don't really, if we want to get better in certain cases, there's only so much that complementary alternative medicine, over-the-counter stuff can do for us. We have to participate in this market. So it's really not like, oh, there's this free-flowing no entry or exit barrier. Does anyone else have an example they want to share along those lines? You can feel free to just share anything. It doesn't have any personal story, or it could be about a patient encounter or something you all have been discussing.
I guess one thing that I was thinking about recently kind of regarding this was the insurance companies and how they'll change formularies. And I don't know how much that might apply to this. I feel like it does to some extent because the patient doesn't get to decide what's on the formulary. So if they have a medication that's needed and the insurance used to cover it, for whatever reason, they stop covering it for the next year, and then the patient's out of luck. So I just feel like that's kind of a huge issue on the patient's behalf. Um, yeah.
That's a great example, Steve. Yeah, absolutely. Once things aren't on formulary anymore, it's not only a headache for, physicians who want to do right by their patients or try to get something. It's a really big headache for the patients, especially. It sucks to, have been depending on something and all of a sudden you can't get access to it. maybe for many, many years. I had a friend on a migraine medication that's happened to. And it's just tough. Sometimes there are good reasons that make sense, they're based in science, but oftentimes we're just left with a lot of questions and no answers to that. Absolutely.
I'll add real quick something I thought of on that topic because we've talked about how today a lot more of the emergency rooms or the physicians working there are being contracted out, and so a patient who has an emergency situation might have to go to an ER and be treated by ER physicians there that are not in network, even though the hospital itself might be in network for them and to pay higher fees, and so that's just an example there how they don't actually have choice.
Absolutely. That's such another good example. It's horrible, like when you're forced into situations like that, you don't have a choice. It's also very just disempowering. And we wonder why patients don't have trust in our healthcare system. It's like eroded so much. Thank you for both for sharing those. So I guess we can go on to the next one. I want to continue this. I like this style of like us having more of a conversation on these points. The next principle, the fourth one is about this perfect information, right? Seems a little bit silly to continue with this example. We'll go with it with the pencil. But all the choices are usually in front of you. If you really want to get online, you can look at all the types of pencils out there and major manufacturers, the pros and cons. But it's not hard to get that information at the end of the day for most people, especially in today's day and age. There's easy access to all options. That's why we went with something like a number two pencil, because most of us can go into a store and find the majority, 95% of choices at a price point most people can afford in a lot of parts of the world. Whereas in the American healthcare system, it's really hard to know enough information in the first place to shop around. It's not so much that you even like have access issues in the first place. It's like you don't even know what to be looking for, what to ask, what to think about when you're looking at different products, different services, and even different physicians that you're trying to like potentially go to. You're thinking about a lot of factors. It often comes back to the financials, but like there's so many things you have to keep track of, and there's so much hidden print there, or fine print, hidden information that you just won't have access to because it's specialized knowledge. It took so much, time for us to all learn this knowledge, and we're not always the best at disseminating. We're not always best at health literacy and getting the information out. And there's a lot of trade secrets. There's so much information that pharmaceutical companies keep locked down. Emergency scenarios don't allow enough time for people to do their research. So a lot of times we're having to get health service provision because we've landed in an accident or just something has come up. We don't have time to do our homework. Even if we're really educated and on top of things, we just go to the nearest practitioner or hospital and we get what we need. And then we just deal with the consequences afterwards, the bill, um, you know, potential side effects, whatever happened. So it's really not following the free market here either. Does anybody else have anything to add here?
I can say I was just recently looking to make a primary care physician appointment. And I'm like transitioning out of adolescent medicine and getting like a adult doctor and whatnot. And I basically just went online to my insurance company and saw which provider had the first opening. And even then, I wasn't able to get an appointment until November. And I was like, well, this will have to be good enough because this is the soonest I'm going to see someone. So having to make that decision over like necessity of seeing someone and being able to update my health records for school versus like actually being able to look for who I would want handling my medical care.
I'm gonna say, yeah, that's really frustrating. And it's like, we're only limited. We have so many priorities and we have to be practical oftentimes. It doesn't seem fair. Oh, and then I think Kai, I hope I'm pronouncing your name correctly.
Yeah, you got it. I know some issues some friends of mine have run into, and as well as some family members, is with pharmaceuticals. So like a doctor will recommend a medication that ends up not working for them or causing a larger problem. And then they kind of have to like pick and choose what's within their insurance and also what works for them and what's recommended from the doctor, and it can become overwhelming.
Yeah, absolutely. It's like that and paralysis of analysis and having too much information you don't know what to do with. And then Macaulay, I think.
Yeah, I just think that that timetable thing is like so important and so unique about medicine. Certainly, there are other, markets that are selling things that are important. But I think the timetable on medicine is all often so fast, even not in an emergency situation where you really don't have time to like research. Like I take a medication that the generic has been in shortages and on back order, like off and on for the last year. And when I can't get the generic, if I have to get the name brand, it's $300. It would be 15 if I could get the generic. But that's what my formulary is. That's what my insurance covers, right? But it's like, I'm a busy med student. I could call every single pharmacy in town and ask if they have it. I'm pretty sure they don't, but I could, but I'm not going to because I have limited hours in the day. I got to go get my medicine. I can't just be unmedicated. So I think that, like, I'm not a willing participant in that interaction. That's not an interaction I'm having about like shampoo or like deli meat.
I like those other examples we should use in the future, maybe, but shampoo. Yeah, exactly. It's definitely not on the same scale of just like, oh, yeah, I'm willing to like forego this. I need this, and I only have so much time, limited resources, one of which huge main thing is time, often and money. And I have to get things done. And this is just creating more complications in my life, more stress, and maybe leading to more health problems, actually. So it's a huge problem actually that we don't have like perfect information or perfect situations of shopping around. I guess we can move on to the next point, which is, oh, here we go. Benefits come from payment. With the number two pencil, the idea is only those who pay for the product get to use the product. That's kind of what benefits coming from payment ties to, really simply put. We get that. It's pretty easy and self-evident with the number two pencil. You can pass around our pencil, everybody can use it. But, ideally it's just like we have an example in mind of something maybe we're eating. We bought it, consume it, it's very clear relationship. Whereas with American healthcare, oops, sorry guys, I was trying to move this over. Should people who can't afford to pay not be provided healthcare? That's a question to sort of mull over, maybe we can discuss, that ties back to this point. Because at the end of the day, everyone benefits from a healthy society. I think that we're all in this internship in this program on board with that, but it's okay to have differing opinions. If you do, we can discuss. But the idea is like, when you provide healthcare to one individual in a way, you really are helping a whole community. You do that at scale. Like we see that, of course, with immunizations. We saw that, I think, a lot with the pandemic. There's so many other examples we can bring up. But really, we want a healthy workforce. We want our teacher, we want our next grader, we want everyone to be healthy for a functional society in which we're happily cohesive and living our best, thriving lives, right? And not in sort of just like an idealistic world, but really just in a very pragmatic sense that's important. And we see that with medicine, with so much of medicine. But so I'm going to pose that question to you all in relation to this point, number 5. What do you all think those who may not agree with this would say in return? Should people who can't afford to pay not provide healthcare, is it true that we're saying, yeah, like it's not obvious that just those who receive healthcare get the benefit from it? You can go for it, Kaya. And yeah.
Okay, sorry, I didn't realize we were just gonna shout it out, my bad. I live in New Hampshire, which is kind of a unique state in a way politically. We have a lot of people who have we're first of all, we're an older population, and there are a lot of people who both have like blue collar jobs and like really high paying, I don't know, like really high paying office jobs or a really high paying job. And there's a difference in opinion politically whether people move more blue or more red. And the argument that I've heard for why people don't want people who can't afford healthcare to have it is that they don't want to be the ones to pay for it necessarily. Like there's this impression that it's going to put a larger burden on, say, like the middle or lower classes to pay for this healthcare, and they don't necessarily want to do that because everyone wants to keep their money and everyone wants to be rich, but I don't know how true that is.
Yeah, I'll just add to that because I was going to make a similar point. I think a lot of people would, if posed that question, should people who can't afford to pay not be provided healthcare? They would probably say like, no, they should be provided healthcare. Just I'm not going to pay for it. Like that's like the work of like charitable organizations and like religious groups, but like not a social good, and the government should not be in charge of that. I think it's an argument a lot of people would pose.
It makes me think a little bit about we had like a public speaking lecture a few days ago, and they talked about like maybe one of the main questions that you'll get if you ever give a single payer one-on-one presentation is like, oh, I've worked for so many years and like have this great pension and I don't want to give up my benefits. So why should I do that for people who like can't afford care? And I think one of the points they made was it would be cheaper for everyone if we like ended up providing everyone healthcare, like and all were kind of in the same risk pool. Everyone would pay less for the most part.
I think also in the US, like insurance being tied to employment, there is a group of people who I think are worried about losing that incentive for people to work. I don't agree with that necessarily, but that is something that I see come up a lot in articles and interviews where more conservative uh, leaders are kind of talking about why they're not on board for measures that would extend more healthcare to more people, is that people might not want to work anymore.
I think just as Macaulay pointed out, this question really leaks into the political landscape of the country. In a recent book that we read, The Hospital, I don't know if you've heard of it, but it talks about like how the AMA is kind of against like opening free clinics and like improving access to care who may not afford for low-income families. And I think it's really interesting to grapple with the fact that this issue is not just like limited to healthcare, but it's intersecting with different political and social identities, as well as like there is this concept, as we all alluded to earlier, of like if other people get more rights, more access, more resources, then it'll be coming from me. But rather than people think like that, but maybe the approach should maybe be that everyone benefits. It might be helpful to implement that ideology. So and back it up with facts and scientific data if we really want to have universal healthcare as a society. But sorry, it was a long rant.
It's definitely not a rant. It was great. And I have read that book, and honestly, yeah, I'm glad that AMA has come a long way and still has a long ways to go, as many organizations do. But it's a fundamental question that comes up a lot. And I think it's one that it's good that we all discuss because there's so many angles to take and there's so many different, understandable reasons why someone might not feel this is a true or false, or also just like, do I want to support it? Even if it may be true. Like, so I think it's great that we're having this discussion. I liked a lot of the points you all brought up in terms of whose responsibility is it, why someone might not, from even a productivity standpoint, from a social functioning standpoint, just like we're like saying, oh yeah, having a healthcare provider everyone actually makes us all healthy and functional, and we're keeping the economy going and we're doing the best with our lives and our social organization. Someone could say actually can also be opposite. It seems I don't agree with that point and you take it out further, but I can see why someone could jump to that. So this is a really helpful discussions, points to keep in mind of what others could say. But ultimately, I do feel that we can see readily that, number 5, that principle doesn't really apply to the American healthcare system currently. So then going to number 6, this is a principle, price accounts for all the costs of a given product. So going back to our, example of the number 2 pencil, price driven by the market forces generally accounts for all the labor, manufacturing that went into it, the infrastructural costs associated with in production and then selling retail. And this may or may not include environmental damage, but overall gets pretty close to meeting number 6 versus something like the behemoth of the American healthcare system, as we were talking about earlier, hospitals and clinics are the price makers. There's a huge excessive administrative burden, and I'm sure that's come up in your internship or will, but like so much of the excess cost goes to things that are admin. That if we eliminated, that if we had potentially a single payer system in a model that worked, we could eliminate that. It would, get at like potentially eliminating jobs, and we'd have to have a pipeline and think about those things and repercussions. But it's true that a lot of that cost gets eaten up by administrative burden. So it doesn't really, meet the number 6 guideline. And this notion that price will account for the cost of other care, not just yours, which then again, going back to number 6, price really doesn't account for all the costs of healthcare. There's so many hidden costs, and that goes both ways. So we can see readily that this principle doesn't fit. And then I'm going to possibly just jump to number 7, and then we can have a bigger, more robust discussion. So number 7 is getting at profit maximization. And it's simply put, like, that at the end of the day, there are overarching objective is profit. And with the number 2 pencil, it's pretty clear. Something similar, we could have used as another example. It's pretty clear, like, yeah, the manufacturers want to make a profit at the end of the day scale. And well, we can say that actually the American healthcare system maybe does fit number 7 because it is profit motivated. It maybe does fit this principle of the 7, but really shouldn't be, like, I think would all agree that it shouldn't be. If we are coming off of the foundational notion that health is a human right, or that healthcare is something vital to us on our hierarchical needs, and really that there's so much waste and so much unnecessary stress, all the different pain points in our society when we have it profit motivated. So this is one of those principles, well, maybe it does meet, but it really fundamentally shouldn't be. What do you all think of that?
I know my opinion is kind of like, I feel like the fact that it was profit make motivated, or it is now. I feel like it should have.
It's an interest.
Oh, go ahead. Oh, anyway, I guess I was just saying that I feel like the fact that it was profit motivated should have resulted in improvements. That's at least what I always thought would happen. I mean, I don't want the government making my cell phone. I actually think we get a lot better result from the profits or from profit motivation. All that said, obviously we tried it; it's not working, and I think it's time to move over onto the other area. But I would go for whatever worked, honestly, at this stage. I really don't care whether it was called profit motivation or non-profit. We've tried one, and one of them is unsuccessful, so we need to go to the other one.
Yeah, that's such a good point. Like, even if it meets this principle, with 7, it clearly isn't working. Like, it's not getting at the results and outcomes you want.
I guess one thing that we did talk about, I think at the very first day of our internship, is like the primary care shortage. I feel like because healthcare is in the US profit motivated, that is one of the contributing factors. And primary care has such huge implications for the rest of the country's health. So because primary care, pediatrics, they might make less than neurosurgeon, there'll be less people applying for those type of residencies. So that's kind of what contributed to the shortage to at least some extent. So I think that's just one maybe downside of why profit maximization shouldn't be the key for US healthcare.
We've also talked about how like essential services like OB/GYN, psychiatry, and pediatrics in hospitals are like essentially where they lose money, so they kind of cut those services first. And they're kind of essential.
Yeah, I think what's most necessary is not necessarily what is most profitable. And that's true for, most things that are public goods. I mean, when you think about like education, if we ran, elementary school education the same way that we run our healthcare system, would be insane. It would be insane. And only some people, you know, would it would be nuts is the point. And we don't run it that way for a reason. We know that it's not profitable. We know that you just have to do it. Somebody's got to do it. Somebody's got to be, you know, a primary care physician, even though it's not as profitable as running, you know, the oncology clinic.
I also think like across most socioeconomic backgrounds, communities are able to come together to collect things like pencils for school fundraisers or extra pairs of socks and gloves in the winter time. Um, Even like food drives around like holiday seasons and whatnot. But when you're talking about hundreds of thousands of dollars of medical debt, like suddenly that becomes a lot less obvious as something that a community that all communities can rally behind and be able to collect together and move towards that. So like kind of harkening back to when we were discussing, like, well, I don't want to pay for someone else's healthcare. Maybe it's the job of like charity or something like that. You see it becomes much more difficult when you're talking about how high profit and how high stakes the system we're working in right now is.
Yeah, one thing that I would also add is kind of like, fostering a profit motivated healthcare is then allowing a lot of unethical practices for people who want to maximize their profit, be it physicians who are like doing overdiagnosis, upcoding, or like forging stuff, which I think we talked about yesterday, or like the hospital that are like forcing them to do that, or like creating a pressure where they necessarily the only way that they can survive or pay off their salaries is by doing that. So I think like that is the ramification, which wouldn't be if it is not profit motivated.
Yeah, on that.
Oh, sorry, go for it.
No, I was just going to say on that point, I think what we have seen in our current system as we've studied it more and more is that you have everyone basically trying to game the system to maximize their profits, whether that's the hospitals, the insurance companies, the pharmaceuticals. Everyone's trying to work the system the best way they can to maximize their profits, but ultimately it's like upon the exploitation of like someone else's health, which is I think is fundamentally wrong. And it's why like, the profit motivation here is just not it makes the waters really murky in the healthcare sphere.
I think another element is profit motives. Profit maximization tends to be like short term. And so like the examples of closing up those clinics of OB/GYN or behavioral, they just straight create sort of like chronic conditions that in the long term cost way more to deal with rather than sort of like preventative in the short term.
Yeah, these are all amazing points, you guys. Like on every point, you guys hit it. Like just, in terms of the ethical quandaries that come up, the dilemmas, just like what's at a loss, what the nuances are getting at in terms of our training, the debt, the types of essential care, and things that we need to think about, whether, in answering this more fundamental question of what the current structure is and if it should continue to be that way, what we're losing currently. And continuing to lead on. So this is kind of just going again over those 7 principles of the free market that we've now sort of briefly touched upon in this walkthrough exercise. I had a breakout room question, and some of it we may have already covered in a nuanced way going through these, but have you all, maybe we'll just ask in the general Zoom. I think it's fine. We can have a little bit of discussion on this now if there's time. How have you all seen microeconomics and healthcare being discussed and applied throughout the internship so far? So you've already like provided great examples and alluded to that. What are the consequences of assuming healthcare does follow the free market? We've also just been touching on that in different ways, but just go for it in terms of like maybe highlight a principle and the consequences.
Shivani, let me just interrupt for a second.
Oh.
How are you?
Doing well. How are you? I literally just moved states today this morning. So I'm just like,
wow. No, that's terrific. Thank you for doing this. This is
I'm so glad. Yeah.
Discussion. I just want to add to the conversation about profit, just to realize that much of our healthcare is through public tax dollars. And we have a system where our public health dollars, which are supposed to be directed towards medical care are directed to profit. So, and the mechanism was believed to its origins, for instance, Medicare Advantage, which contracts with the Medicare system. The intent was, oh, we're going to be more efficient because we're profit motivated. Clearly, that's not the case when you're diverting a health dollar towards a CEO salary or a stock traded fund on Wall Street. You're diverting dollars away from what its intention is. So the other thing just to think about is not just a for-profit world, but also a tax-funded system that's being diverted into the profit world. So I think that's just another important take-home point. That's all I wanted to mention. So if
That's a great point. Thank you so much for making that. Does anyone potentially want to take a stab at this in terms of like the second part of this, taking one of the principles and what would be the consequences of healthcare to follow the free market per that principle, or even all the principles taken together?
I think the principle that people have in a free market access to information and therefore they can shop around. I think that has this consequence with reference to healthcare that I was thinking about a lot when we were reading The Hospital, which is that we kind of create this culture around health that is deeply rooted in like shame and blame, and it is always the individual's fault, and it's a failure of personal responsibility. If bad things happen to you in healthcare, if you are horribly indebted to some medical system, you did that to yourself. Like I think that is a sort of inherent undercurrent in a lot of the ways that people, I think, kind of unintentionally talk about healthcare, both like lay people and medical professionals. I think there's always kind of this attitude that people should be doing everything that they can to take care of themselves, and they should be looking out for themselves because I'm looking out for me. You should look out for you. Nobody's going to look out for you, right? But it's like, isn't the health system here to look out for you? Like, what else are we doing? I didn't go into medicine to be like, I'm not here to look after anybody, right? I'm here to look after people. Yeah, like that's why I wanted to do this in the first place. But I think that kind of like, this is a commodity, therefore it's something that you can research, therefore it's something that you can plan. It invites you to blame people for their health circumstances.
I totally agree. Oh, oh, sorry.
Go for it.
I was gonna say that I was gonna build on Macaulay's point and say that like we don't within this culture of blame, we also don't have healthcare literacy. I mean, it's not like you can go to a doctor's office and they share like this is how the healthcare system works. Like it's you figure it out as you're in it. So, if we don't have like this way to educate people about like the healthcare system, I don't I don't think you can actually really blame them. I mean, I didn't know much about it until this internship where I learned about things like private equity, about like the reimbursement. Like I didn't know anything about that. Like I was just, going to my doctor's office and then I didn't know what happened behind the scenes and like with this whole system. So it's just like I think it's just a lack of literacy on that on the system, I think is part of the access to information. Like I don't know where to find the information. Like it's not easily available.
I think expanding on that, the not having perfect information and one of the things from like benefits from payments, we've mentioned a lot about prior authorization when it comes to things like Medicare Advantage plans and some extent like the other privatization. But I think that's another great example of like how it breaks like the economics because you pay for a service and then you don't really find out you don't get it until the last moment. Or It's also not readily available as to like the specifics of like, oh, this doctor cannot prescribe this medication for this reason. You really only get that last minute. And by that time, it's like, again, really hard to shop around and find somebody else when you're in a moment of need.
Specifically, also, I think we've been talking a lot about administrative costs and how much money is lost to administrative costs. So on those same lines, that's, following the free market is increasing these unnecessary, administrative building, like whatever processes it may be. And also to touch on, I believe it was Hamza mentioned this, but in terms of preventative care, definitely we're losing that long term. The consequences of that are, of course, increased costs down the line. So that's just gonna, build and build.
To answer the second question, I think a free market is only really functional if the good that's being sold is not necessary for life. So what we've been discussing recently, like as far as like the pencils or like shampoo, people have an option. Too expensive, I'm going to look for another seller. Or you know what, that's too expensive, I don't even want to buy it. Like forget it, I can live without it. So I think that now if we're applying a free market to healthcare, it's exploiting sick people because these people don't have the option. They're not going to say, oh no, it's too expensive, I'll just live without it, because they literally can't live without it. So I think there's a lot of immorality and a lot of exploitation that comes into play as a consequence.
I also think to add to that, when you're trying to apply healthcare due to like expenses, but also because like if you're assuming that there's a free market, then you're assuming that there's supply and demand. But if you live in a rural area, there's not much supply in the first place. So having someone in a rural area, even the option for them to shop around is not really feasible because in this day and age, we have a free market as in like, oh, I want to buy a book. The book is too expensive at the local bookstore, but oh, Amazon can deliver it to me, even if I'm in rural like California or wherever, Washington. But you can't really do that with healthcare, right? Because you can't have a neurologist delivered to your door to help provide that supply. I know there's telehealth, but telehealth can, be so limited in what you can do. So I think that's another way.
I don't know exactly which like principle this would fall under, but I also just wanted to point out when I learned this, it was pretty crazy how the price they charge for all the services and all the techniques and everything in the hospital, how it's just like a made up number, like doesn't actually like relate to like how much it actually costs to perform it or supply it. And then once again, it's just like falls on the patient. That was just crazy to me.
I also want to add on like to Hamza's point of like, sometimes you don't know the price until the last minute and you kind of have to just like go for healthcare. And sometimes even when you like, like your insurance, like back and forth, like what your copay is, you get hit with a surprise bill after what you had whatever procedure done. It's really frustrating and hard to fight. We talked about how challenging like appeals can be.
Yeah, you guys have made amazing points, and so such a rich discussion has unfolded because it's true. There's like we just don't have the same kind of flexibility to pragmatically shop around for healthcare, especially in emergency situations for necessary care, with limited information, limited finances, and networks. And there's a lot of just volatility. Like there's so many things that just fall out of market or like fall out of network, and we're left without many options. We're left in a bind, and it's just not a lot of clarity on both sides. Points around health literacy were brought up around how we just can't, shop online easily for replacement. It's not easy to replace a great physician relationship or the product that you absolutely needed. Not all insulins or X type of drug are the same in quality and in terms of how they may work for an individual. And it is true that there's so much we don't understand about what we get tacked on with the cost of a healthcare bill or a hospital bill, especially urgent care bills is something that I worked on a project with and try to increase med student and other young professional knowledge of how to interpret and understand hospital urgent care bills to help explain that to patients and walk them through, but also to understand problems with them, the equity issues and high value care issues. Because at the end of the day, given the way the current system operates, you can argue that they are going to want profit. We just talked about how that maybe shouldn't really be the motive and it's not working. But it's like, okay, so there's going to be some additional cost, but it just seems so disproportionate. It doesn't seem, it's just unpredictable. And it's just so widely varies from place to place, hospital to hospital, and it can be really predatory in for certain populations. So you guys brought up so many amazing points. I don't know if there's anything else we want to discuss or what you all have planned next, but I was going to ask maybe your part Ken or others to jump in. If they're still on the call. You can also just, I mean, is there something you guys are hoping from the internship, like by the end of the internship that you're like, if posed with an argument around how do you think this is useful? Like if you're speaking with someone who may be against single payer of any sort, you know, operating within the US healthcare system, do you think it's useful to be equipped with this knowledge? To be like, well, what is your viewpoint? Do you really feel that healthcare in our country follows a free market, follows the principles of microeconomics, works like other products, that you can use sort of an economics line of arguing, debate to have a different kind of discussion than sometimes is there? Because a lot of times it falls back on values and emotions. And I think this is just another really cool tool in the toolbox of things you can use to have like an informed discussion around a different way of looking at things. It sparks so much good discussion, right? What do you all think though? At the end of this internship, what are you hoping you'll leave with out of this lecture, like how you can use it?
I just kind of wanted to understand the language a little more. I feel like anyone, regardless of what position they're going to go in with health, should know how to navigate the system in which they work. And I think that it, I don't want to say it's a bad idea, but I think you can only you can only do good by knowing more about how the system works as a whole and how you're going to work within it.
I
Yeah,
think, go ahead, Gabrielle. Sorry.
sorry, Dr. Dolkart. I was just gonna say, we kind of discussed during one of our earlier morning calls, like very briefly, kind of the political scene and what's going on and the recent debates and whatnot. And I think there's kind of the perception dirty politics. And I think having different ways to approach problems and interact with people and meet them where they're at and where their primary concerns are creates a much more constructive and collaborative environment for moving forward than, as you mentioned, trying to take like the low blows on like, oh, well, you just don't like value human rights or whatever. Being able to have this like economic approach and discuss it from that viewpoint, I think is really valuable for connecting with people that might not be on the same mindset of you, but open to learning more and having those conversations.
Those individual experiences are in our system. And as Shivani pointing out to folks just how does it have to be this way as you do your research on the experience in other countries and across borders not far from here, folks not just giving up on health systems as failing them, but raising the likelihood that they will improve if they look at how our system is structured. Because I think that consciousness raising in your conversations with folks is important for people to recognize it doesn't have to be this way. It could be a lot easier if your dollars are actually going to medical care rather than CEO's profit. But this is really terrific, Shivani.
I mean, it's really terrific only because honestly, all of you made it that way. You guys are just so bright and so excited. And I'm not that farther along from you all in my own medical training journey, but it's just so cool to see the internship continue to bring really inspiring, dedicated, hardworking people on board who want to do something, want to inspire change, and are like happy to do the hard work to make that happen, to think outside the box, to have these kinds of uncomfortable conversations with colleagues and friends. They don't have to be uncomfortable, but it can be at first. And so I just am so amazed. And I thought you've taught me so much more and reminded me of things that I've learned that I haven't thought about in a while. So it's really cool. I wanted to say, hey, I've been having my video off. It's a little bit unstable connection, but it's nice to see everyone too.
Great to see you.
Shivani, I would love, sorry if I could, I would love to just ask how you plan to use like the knowledge you gained from the internship and the other advocacy work you've been involved in since, how you plan to use that moving forward going into your career.
Wow, that's a big question, but I'm glad you asked because it's an important one. I feel like I've continued to use the knowledge I gained from this internship so much more than a lot of even like public health policy classes or the similar kinds of classes I've learned, had to take in medical school and elsewhere. And the amount of like history, practical knowledge, cool conversations we got to have with all the different guest speakers, opportunities through this to be interviewing, to be on a radio show host, or like to do collaborative projects with other students. I still am friends with a lot of the people I meet through this internship, fully virtually. So that's pretty cool. We've met up sometimes, and I plan to continue using this knowledge in a very practical way all the time when I'm having conversations with future patients and other colleague physicians. Like, so with high value care and a lot of the advocacy work I do with the AMA or even like Louisiana State Medical Society, so many little nuggets I keep coming back to with this. Like around, again, framing the conversation around economics, making it more about the evidence out there and not just people's opinions or like values that they feel like an emotional, stance towards. And there's some great lectures I took away from the internship around how to navigate conversations across party lines, political lines, that I still always come back to. I mean, it's amazing how useful that is in terms of having conversations with people with diverse perspectives. And then around being a good public speaker, still learning and still practicing the skills you guys can see from Dr. Weisberg's talk on that he gave us. I still talk a lot about, I think a lot about other countries and other models and how they've developed and do things. My year, I worked with another student who's now going on to become an OBGYN. Like we did one about France and this development of its healthcare system. And we had a lot of fun researching that, putting it together, and we're still friends. We're still friends. And we have even since over the years come back to that. And I use that sometimes because people have like, oh, you mean like single payer like the UK or like Canada, like they have really simplistic or narrow views, or maybe they just haven't like learned about different ways single payer could potentially work and different models of development. So it's nice to have all those examples from everybody's presentations. I still have those PowerPoints I come back to. So like on a day-to-day level, yes, with patients, with colleagues, I plan to continue to advocate in my career long-term to stay involved in the policy space, to stay involved with PNHP. I want to write articles and want to continue to mentor others, to teach, to learn from others. And I hope that after like medical training, I'll have even more time, which I think I might in residency. I don't know. This last year was pretty busy for me. And, I plan on working with populations that are not always seen, those with skin of color, those who are underrepresented. I want to be another voice in the room, lifting up others and making sure we all have our voices heard. And I think a lot of the lessons from this internship apply there too, around health equity. But yeah, like what about you guys? I don't know if you have time to have more discussion. Like what are some things you all plan to do with things you're taking away from the internship this year?
Well, first of all, I'll just say thank you so much for sharing that. Yeah, it's really awesome, and I'm super excited for you and wherever life takes you. I think for me personally, yeah, I'm still really figuring it out exactly what it looks like. I think that kind of as Kai mentioned, I really just want to do the best to kind of get a bigger bird's eye view of the system that we're usually boots on the ground in, and that's important work too. But I think you have to have a larger understanding and perspective of what's going on outside of you and how that's affecting your practice and your patients. And so, yeah, I definitely hope to continue to be able to advocate that, everyone has access to healthcare. I think it's just a fundamental right. And I think I'll take everything from this internship and use it towards those purposes.
I'd love to do some work in the laboratory with like prices and advocacy for that. Because I feel like a lot of lab people currently, they're the generation that used to do mouth pipetting. Like there's not a lot of new bodies, new minds flowing into it. And also like I think from when we were talking, the impression I got was that the majority of medical expenses itself comes from the lab. So it'd be interesting. I'd be interested to see what kind of things I can learn and what kind of advocacy I can do with that.
I'm interested in like OBGYN, that kind of space. So I definitely am thinking of combining this with kind of like a women's advocacy standpoint. So I think that that's a really strong background to have because both of those topics have such vast histories. So I think that that's something that I definitely want to incorporate in the future.
So Kaya mentioned this about how important it is to like kind of know about the system that you're engaging with, like healthcare system, especially like as a lot of us are in like medical school. The fact that there really, there's like some public health classes and some like med schools, but most people's most med students first exposure to how the system works is when they're on rotations or like clinicals or residency even. So I feel like being able to like obtain as much information as I can and then share it with my like fellow peers so they have a better understanding of how the system works before they're kind of like too immersed in it without even realizing. So they can be better advocates by knowing as well. So I don't know, I like to share the info.
That's really cool. You guys are gonna do amazing things. And like such different things. I also laughed about the mouth pipetting. Because I did some basic science and visual and organizational research this year, and there's still people mouth pipetting. But yeah, I think that's amazing. And I'm so excited to see where all of y'all's careers take you.